I'm very grateful to BJS Academy for asking me to record this lecture, which was given at a number of institutions in the USA that I visited in October of this year as part of my American College of Surgeons John D. Corson International Guest Scholarship. I presented these data in Stanford Vascular, Duke Vascular, and Massachusetts General Hospital Vascular Surgery. So just a little bit about myself to set the scene. So I was born and brought up in Northern Ireland. I attended medical school in Edinburgh, where I also completed foundation training. I then moved to Bristol in southwest England to undertake core surgical training, and subsequently got a national training number in a national training number in general surgery in southwest London. During that training program, I actually moved back to Edinburgh to do a PhD. I ultimately transferred deaneries to Scotland and transferred onto the new vascular curriculum in the UK and finished my vascular training predominantly in Edinburgh, where I am now a consultant vascular surgeon. So as I mentioned, this presentation was part of my recent travelling fellowship. In addition to being a consultant vascular surgeon in Edinburgh Royal Infirmary, I also have some academic appointments at the University of Edinburgh. I'm a PhD co-supervisor with some active research grants, including a British Heart Foundation project grant. I'm an editor of a number of textbooks and journals, including, of course, the BJS and BJS Open. I've just been appointed as chair-elect of the Circulation Foundation, which is the UK's national vascular charity, and that comes with the position on the Executive Council of the Vascular Society of Great Britain and Ireland. I'm past president of the RULO Club, which is the UK Vascular Trainees Association, and I've also been on executive committees of a number of other international and national groups. I was an editor-at-large in the Audible Bleeding podcasts, and also have had the privilege of travelling to the US a couple of years ago on another travelling fellowship, visiting Houston Methodist, Baylor, and USC Keck. But on to the important stuff. Sometimes in vascular surgery, it's easy to know what to do. So this is a scan of a patient who was 67, who presented with abdominal pain and clearly has a large abdominal aortic aneurysm. And this scan shows that it's got a short neck. So this is a juxtarenal aneurysm. And whilst there's no evidence of rupture radiologically, the patient was very tender and needed an urgent intervention. The patient was obese, as is typical of many of our patients in Scotland. He was a current smoker and had a history of moderate COPD. Ultimately, we decided we needed to get on and repair this patient, and he proceeded to an open repair of this juxtarenal aneurysm, which went well. But actually, if this patient had presented in the elective setting, the decision wouldn't be quite as straightforward. He had a number of high-risk features for undergoing an open operation. And so sometimes it's easy to know what to do, perhaps in this emergency setting, and other times it's a bit more tricky. And why is this? Why is it difficult to decide what to do in vascular surgery when we're dealing particularly with abdominal aortic aneurysms? Well, we all know that size isn't everything. We do know that the risk of aneurysm rupture increases as the size of aneurysm diameter increases, but we also know that this isn't predictable and that aneurysms grow in fits and starts and exhibit what's called a staccato growth pattern. And so we keep these aneurysms under close surveillance, particularly as they get larger. But we've all seen aneurysms that rupture under the threshold set for repair, and we see aneurysms that grow to 10 centimetres or more without rupturing. So there's this element of unpredictability when we're dealing with aneurysm disease. Our treatments are also not risk-free. Whilst over the past few decades, of course, endovascular aneurysm repair, which is a minimally invasive intervention, has been associated with a reduction in perioperative major complications, including mortality when compared to traditional open repair, it's not risk-free. We know that EVAR is associated with poorer durability than open repair. And of course, if we had a treatment that was completely risk-free, then we'd repair all of our aneurysms as soon as we detected them. But that's not the case. Our aneurysms are becoming increasingly complex. Gone are the days when we had a load of lovely, straight-necked infrarenal aneurysms that would be sitting ducks for either a nice open repair or a wonderful endovascular repair. Our aneurysm disease is creeping up the arterial tree towards the visceral segment and beyond. Our patients are increasingly frail, or we're detecting aneurysms in older and more frail patients. And so we've got a number of different things to bear in mind when we're considering what to do with a patient sitting in front of us in clinic who has an abdominal aortic aneurysm. And in fact, this is reflected by this international opinion survey by the Oxford Group when they asked international vascular surgeons what do they think were the research priorities in vascular surgery, and in particular in abdominal aortic aneurysm research. And the number one research priority was the identification of some sort of test that might tell us what an aneurysm is going to do and whether it's going to grow or need ruptured. And this leads me on to biomarkers. Now, we've all heard of the word biomarker, and just to recap, a biomarker is a biological molecule found in blood, tissue, or fluid that is a sign of normal or abnormal processes or disease. And I would actually argue that we all already use biomarkers in our everyday practice. So when we're looking at plain CT angiograms, as we do all day, every day, when we're considering what to do with aneurysms, we already look at some biomarkers like thrombus, for example. We're looking at the aneurysm neck. Is there too much thrombus for us to achieve a good seal with EVAR? Is the neck or the iliac vessels, are they heavily calcified? Are we going to be able to get a clamp on safely? And what's the plaque composition of the aneurysm and the access arteries? So we already look at biomarkers on CT, and I would call these soft biomarkers. But let's take this a little further. So I work in the beautiful city of Edinburgh, and whilst there's a bit of air pollution, there's not so much air pollution as there is around the world. So if we go outside on a regular night at Edinburgh, and there's a clear sky, we can see wonderful stars. And we go to the observatory in Edinburgh, we can see these stars in greater resolution. We can use a telescope to really get a better idea of what's in the sky around us. But taking this one step further, if we were to use the Hubble Space Telescope, this would open up a world that we've never seen before. We can see the world in incredible resolution. We can dive deeply into a universe that's been otherwise hidden from us, that we know exists, but we've never been able to quantify. So I'm going to call this the Hubble Space Telescope of cardiovascular imaging. What this lets us do, these imaging techniques I'm about to tell you a little more about, allow us to understand biology without a biopsy. These are non-invasive imaging techniques. And rather than having to take a tissue sample, which we know, of course, in aneurysm disease is kind of tricky, and rather than having to take that sample and put it under the microscope to understand the biology, we can use these non-invasive, reasonably straightforward imaging techniques to get a better insight into biology in a human being. We can repurpose tracers that we've used for many years in clinical practice and use them to look at disease processes in other areas. So one of the imaging techniques I'm going to tell you about is using sodium fluoride on PET-CT. And sodium fluoride is a radio tracer that's been used in the oncological era for many years, but it's been recently repurposed to look at other disease processes such as calcification within vessels. We can also develop new tracers to look at disease processes that we know a little bit about. And certainly the Centre for Cardiovascular Science in Edinburgh, where I have worked and continue to work, is really world leading in developing new tracers to look at disease processes all over the body. So how do we go about doing this? Firstly, of course, we need to know our biological target. And certainly in aneurysm disease, we know a bit about aneurysm disease. We know lots of different processes involved. There is still a gap in our knowledge and understanding about how all of these biological processes interact. But anyway, we start by understanding and identifying a target, a biological target. And then we need a target-specific probe, something that can help evaluate this biological target. We need an imaging modality that has adequate spatial resolution in order to be able to analyze this. And of course, we need a safe and clinically available imaging agent. So just a little recap about the various imaging biomarkers that could be and have been used in cardiovascular disease. And certainly this is not an exhaustive list, but just illustrates the point that once we know biological targets, we can start to develop and repurpose tracers and other types of imaging modalities in order to really understand more about the cardiovascular system and the diseases we treat in everyday life. So inflammation is a huge part of atherosclerosis. It's also an important part of aneurysm disease. And in particular, we often look at macrophage-mediated inflammation, and there are a number of PET tracers and MRI agents that can be used specifically to look at macrophages, whether that be the macrophage activity itself or whether that be downstream effects of macrophage activity. Angiogenesis can be evaluated by a number of PET tracers, some of which have already been used, particularly in the coronary circulation. Fibrosis, so fibroblast activation protein, and the FAPI tracer is really one that's kind of come to light recently and has been increasingly used, particularly in the heart, to look at the process of fibrosis using FAPI. And thrombus. So, I mean, as vascular surgeons, we deal with thrombus, and we think about thrombus in the acute setting when we're doing a lovely embolectomy and we're dragging some of that nice acute clot out of the lower limb arterial tree. We think of thrombus in aneurysms as being intraluminal thrombus within the vessel, but maybe, you know, it doesn't have the same function as acute thrombus in the lower limb arterial tree. And we also know that there's thrombus implicated in the development of chronically threatening ischemia and chronic atherosclerotic plaques. And I think we've got a bit of gap in our knowledge from that point of view. But anyway, thrombus imaging can be facilitated through various tracers. And in particular, we are about to start looking at a tracer called 18F-GP1. And that's really in the peripheral arteries. And then the process of microcalcification. We all know that calcification occurs in atherosclerosis, and it also occurs in aneurysm disease. We all look at our CTs and we see the bright white chunks of calcification that coexist with the aneurysm itself and perhaps elsewhere in the arterial tree. And I'm going to tell you a little bit more about calcium dystrophy and aneurysm disease, but certainly we can evaluate microcalcification, i.e. the early stage of calcification, using a tracer called 18F sodium fluoride and PET-CT. So the two processes I'm going to focus on for the next little while are inflammation using USPIO MRI and microcalcification using 18F sodium fluoride PET-CT. So firstly, we'll talk about cellular imaging in abdominal aortic aneurysm disease using this thing called USPIO MRI. So the target here is macrophage-mediated inflammation. And our probe is something called USPIO, or ultra-small superparamagnetic particles of iron oxide. And I describe these as kind of tiny iron filings. And essentially what happens is that we know that this USPIO, which can be delivered as an intravenous contrast agent, is engulfed by tissue-resident macrophages. They kind of swallow it up. And then we're able to image this using MRI. And the reason is because USPIO, or these little iron filings that are superparamagnetic, they cause a more rapid signal decay when we use MRI. And what we do is we can do a baseline MRI scan, we can administer USPIO, and then we can do a second MRI scan. And we're really looking at the change in T2 star between baseline and post-USPIO administration, because we see that that MRI signal really decays much more rapidly in states where USPIO is taken up by tissue-resident macrophages. The modality obviously is MRI, and the agent is something called ferromoxetol, which is used in clinical practice in patients with iron deficiency anemia. So I want to start by telling you about the MARS study, which is an MRI in abdominal aortic aneurysms to predict rupture or surgery. So this was a study conducted over 10 years ago now at the University of Edinburgh by myself and two other researchers, and it remains the largest similar study of its time. And the initial MRI work and looking at USPIO as a potential cellular imaging tracer in abdominal aortic aneurysm disease was done by Dr. Jenny Robson. The study itself was initiated initially by Dr. Olivia McBride, and I subsequently took over the study from Olivia and completed the follow-up period. So the MARS study involved almost 350 participants from 3 centres in Scotland, so it was a multi-centre study, using this USPIO MRI in order to evaluate and quantify tissue-resident macrophage activity using USPIO MRI as a surrogate. So, as we mentioned, USPIO causes a more rapid MRI signal decay, and through a series of reasonably complex image analysis processes, we were able to categorize patients into either being USPIO positive or USPIO negative. Now, let me just take you through that. As we can see on the left side of the screen, we have a color map representing a patient who is USPIO negative. So in terms of what the colours mean, what we're looking for is red. The red colour represents areas of USPIO uptake. And on the left-hand picture, we see that the majority of the coloured image is blue, and that just represents the aortic wall. So the blood pool lumen is left uncoloured in the middle of the colour map. The red material is found to be against the blood pool, so it's not actually adherent to the aortic wall. And what we found was when we analysed patients with periluminal USPIO uptake only, it wasn't representative of macrophage-mediated inflammation. So we were looking specifically for areas of significant USPIO enhancement at the aortic wall. And you can see that nicely on the image on the right. So you see that nice color map, which again has some periluminal USPIO uptake, but also has this nice discrete area of USPIO enhancement at the aortic wall on the top part of the aneurysm. And so we were able to take our 342 participants, scan them using the technique we already mentioned, and divide them into USPIO negative and USPIO positive. And we had 43% that were found to be negative and 56% found to be positive. We then went on to follow them up, initially over almost 3 years. In terms of our clinical outcomes, as anticipated, really, our patients, their outcomes are not wonderful. So over the course of follow-up, and with a mean aneurysm diameter of about 53 millimeters in the cohort, 5% of all of these patients went on to rupture. Over a third of patients had a repair, and almost 15% died during the course of follow-up. And in terms of USPIO's ability to predict or be associated with clinical outcomes, our primary endpoint of the MARS study was the composite outcome of rupture or repair. And what we found was in those patients who were USPIO positive, i.e. there was increased areas or increased uptake of USPIO at the aortic wall represented of tissue-resident macrophage inflammation, we found that they were significantly more likely to rupture or require repair. And similarly, in the group of USPIO positive aneurysms, their aneurysm growth rate was significantly greater over follow-up than those who were USPIO negative. And we've just illustrated that on this Kaplan-Meier curve. But when we put all of this into a model, adjusting for the usual risk factors for aneurysm progression, such as baseline aneurysm size, of course, such as current smoking, hypertension, age and gender or sex, we found that actually USPIO uptake was not an independent predictor of aneurysm disease progression. And in fact, what we found was aneurysms that were larger tended to have more evidence of USPIO uptake or macrophage-mediated inflammation. But when we looked at a subgroup of patients with smaller aneurysms, so aneurysms less than 5 centimeters, of those patients who were USPIO positive, actually they had twice as high rate of rupture and repair than small aneurysms that were USPIO negative, which was quite an interesting finding in our subgroup analysis. So then we went on to look at a subgroup of people in the MARS trial and pivoted a little bit into molecular imaging in abdominal aortic aneurysm disease using 18F sodium fluoride PET-CT. So of those 342 patients in the MARS study, we took a small group of them and did another imaging study. So the target this time was microcalcification. The probe this time was fluorine 18 sodium fluoride, or 18F sodium fluoride for short. And the modality was PET-CT. And just briefly a little bit about calcium dystrophy in aneurysm disease. Now, we already mentioned that we know that calcification is a feature of aneurysms quite typically, and we see that on our CT angiograms. But what we looked at with sodium fluoride PET-CT is not the laying down of heavy macroscopically visible calcification, because we can see that on our conventional CT, but we actually wanted to look at the step before that. And we know that calcification is involved throughout the initiation, progression, and quiescent phases of abdominal aortic aneurysm disease. Initially, when vascular smooth muscle cells undergo apoptosis, leading to the laying down of hydroxyapatite lesions, or these little kind of of microcalcification lesions, the coalescence of spotty calcification that cannot yet be seen on CT, but can be identified on PET-CT. So these lesions of microcalcification are beyond the resolution of conventional CT. And then they go on to be laid down as this kind of hard calcification that's easily seen on CT and that we see macroscopically when we're repairing aneurysms, that kind of thick stuff within the aortic wall. So it's the middle process that we aim to identify using PET-CT. And we did this with the SOPHIA study. So again, this was a sub-study of the MARS study, and this was my PhD project. Sodium fluoride imaging in abdominal aortic aneurysms. In 72 participants from the main trial, we undertook sodium fluoride PET-CT investigations and followed them up for around 18 months. And in this group of patients, we looked at the uptake of sodium fluoride in the abdominal aortic aneurysm, and we were able to group them into tertiles of sodium fluoride uptake. And what we found was in patients with the highest uptake of sodium fluoride in the aneurysmal segment, i.e. tertile 3, their risk of rupture or repair was significantly higher than those in the lowest tertile, tertile 1, or the medium tertile, tertile 2. And that's over a follow-up period of 18 months. And so we found that about 15% of those with high uptake experienced rupture or repair versus 5.6%, so almost 3 times as much. And when looking at aneurysm growth, we again found that those patients in tertile 3, so the highest sodium fluoride uptake, expanded their aneurysms more than twice as rapidly as those in tertile 1. And what was interesting was that when we looked at the Agatston score, which is done on normal CT, so that's a measure of that kind of macroscopic calcification that we see in CT, that was not associated with expansion. And so that leads us back into our theory that, in fact, it's this middle process, it's the progression and the microcalcification stage that is the biologically dangerous stage in abdominal aortic aneurysm growth. Whereas when you start to lay down the macroscopic calcification, perhaps that's the quiescent phase. And that's, that was reflected in the fact that our Agatston scores suggestive of calcification derived from CT was not associated with expansion, whereas our microcalcification imaging was. And so this was the first imaging biomarker and remains to be the first imaging biomarker to be independently associated with disease progression in a clinical study. Because when we adjusted our findings for the usual risk factors for aneurysm progression, and in particular for baseline aneurysm size, for smoking, for sex, and for hypertension, we found that uptake of sodium fluoride on PET-CT remained to be an independent predictor, or was independently associated with both progression and rupture or repair. And so we took this further. So Dr. Sam De Bono, who recently graduated as a PhD student from the University of Edinburgh, he looked at sodium fluoride PET-CT in EVAR because, as we've said, we've got treatment modalities for aneurysm disease. EVAR, which is associated with a reduction in perioperative complications, including death, but is not risk-free, and it's not a 100% guarantee of success. And we know that many of the patients who undergo EVAR will need reintervention. So we're kind of trying to find the reason behind this. Why do patients need reintervention, and why do they develop endoleaks? And so Sam used this sodium fluoride PET-CT technique in patients with EVAR. So 102 participants in his study, and the longitudinal cohort study aspect is still in progress. But in his proof of concept study, Sam scanned 10 patients and found that EVAR reduces uptake in the abdominal aorta, but not the thoracic aorta. And in a case control study, he scanned 15 patients with endoleak and found no difference in sodium fluoride activity in the aneurysm sac, but higher activity in the rest of the aorta. And that leads into our feeling that, in fact, it's the rest of the aorta, it's the neck area that continues to be biologically active. And perhaps that's the reason for EVAR poor, reduced durability over time. In 22 patients who did not have an endoleak, they had lower sodium fluoride uptake in all the other areas, but the same uptake in the aneurysm sac. And then Dr. Maz Saeed went on to look at a similar technique in type B aortic dissection. So a pivot away, a completely different disease process to aneurysm disease, but really showing the versatility and the utility of 18 sodium fluoride PET-CT in evaluating different types of cardiovascular disease. And Maz scanned 67 participants as part of a case control study. What he found was that there was increased sodium fluoride uptake in patients with type B dissection versus controls. And when looking at the entry tear site for the dissection, there was significantly increased uptake of the tracer at that point. And in those who had high uptake in the false lumen, there was greater expansion over follow-up. And if there is high sodium fluoride uptake in the outer wall of the dissection, then there was a greater risk of major aortic events. And that was all over 15 months of follow-up. Now, one of the criticisms of us presenting all of these lovely data using the same kind of technique, the sodium fluoride PET-CT, in various different arterial trees, and originally in Edinburgh, the initial index studies were done in the coronary arteries, and this technique has been used in coronary arteries, in the valve, all over the place, in the carotid arteries and the aorta. And one of the kind of criticisms, understandably, is, hey, you're telling us about this tracer and you keep saying that it does this wonderful thing in the aneurysm, does this wonderful thing in the coronaries, in the carotids, but all of these arterial problems share similar risk factors, but manifest in different ways. And I would agree. So I think the utility and the versatility of such tracers is identifying the common pathways towards the start of the clinical pathway of these diseases, and then using tracers and these imaging techniques to sort of chronicle how these pathways evolve in different disease processes. Because of course we know that abdominal aortic aneurysm disease is a kind of phenotypically very different to other atherosclerotic diseases such as coronary artery disease or peripheral artery disease, and yet they share the same basic disease processes. So we know that calcification in the coronary arteries leads to sort of vessel narrowing and occlusion, along with all the other sort of plaque buildup. Whereas in abdominal aortic aneurysms, we're looking at a disease of expansion and rupture, so phenotypically the opposite. And so my point is that these imaging techniques, once you know your biological target at the start of the process, you can look at that and then see how that target progresses and compare that with clinical phenotypes and the disease progression in terms of clinical outcomes. So the thing is, there are a number of drawbacks, of course. And, one of the things I said towards the start of the presentation was that we do know a number of biological processes implicated in aneurysm disease, but we don't quite know how they all interact. And I think it's important to say the whole is greater than the sum of its parts. And so isolating one process in isolation or evaluating one process in isolation may have limited value. We've just looked at one of these processes, microcalcification. We've looked at another process, cellular inflammation, but there's plenty of other contributing factors to aortic aneurysm disease, which is one of the reasons why we struggle to really predict what's going to happen to an aneurysm on an individual patient level. Perhaps using multi-tracer imaging will increase the information yield. We could use other biomarkers. So I've talked about imaging biomarkers, but there's plenty of other biomarkers found in serum. There are some biomechanical biomarkers that can be derived from our normal imaging or some complex imaging as well. So adding them all into a model, maybe that'll help, but maybe it'll just add too much noise. And recently, I've analysed the long-term outcomes of the MARS study, looking at both the MRI study using USPIO and also our 18F sodium fluoride PET-CT study over a median of about 11 and a half years of follow-up. And in fact, what I found was if I add those two together, so in patients who had high sodium fluoride uptake on PET-CT, as well as USPIO positivity, so high levels of tissue-resident macrophage activity in the aortic wall, those patients had the highest growth rate out of the whole cohort, and they were 3 times more likely to expand their aneurysms if those two characteristics were present. So we're adding value by adding assessment of different disease processes. And so all of this leads us, in my opinion, towards personalized disease evaluation. We've already discussed that we have a disease process that we don't completely understand. We have a high-risk patient group that are increasingly frail. We've got disease or we've got treatment strategies that are not risk-free and that struggle with durability. And so if we can identify some high-risk features of aneurysms, then we can really personalize treatment. And there are a number of ways to look at this. So we can firstly start off with what's called large-scale light phenotyping. We can use routine data we already have, CT-based parameters, such as looking at the anatomy, morphology of aneurysms, the disease burden in the rest of the arteries. We can use big data sets, apply our artificial intelligence software, and try and pick out some features that might be associated with the future risk of progression, rupture, or aneurysm-related events. And certainly various groups are doing this, have already done this, but that's the kind of naked eye approach. If we think about the telescope approach, we might be a bit more we might undertake some more sophisticated CT-based analysis. We can look at biomechanics, volumetrics, and again, there are groups that have done this in abdominal aortic aneurysm disease. We can also look at serum and blood biomarkers in a smaller population to identify any other biomarkers that might be associated with disease progression. But if we go full-scale Hubble Space Telescope, we can use the techniques I've discussed. We can use molecular and cellular imaging to really deep dive into biology, to understand these diseases like we've never understood them before. And yes, they have to be on a small scale because certainly these techniques are not available everywhere. And this is the idea of small-scale deep phenotyping to identify and really hone down on any adverse biological signatures within this patient population group. So what are the clinical applications for these imaging biomarkers? And it is about clinical decision making, in my opinion, but it's not just about that. Well, we can look at clinical outcomes. We've done that in our MRI and PET-CT studies. We looked to see if we could identify patients at risk of aneurysm expansion, at risk of rupture and repair, in order to make that decision. Should we go ahead and repair them? And should we repair them now? Or can we wait for a bit longer and see how the aneurysm grows? We use this to make decisions to intervene, and the particular populations that this could be useful are those with a threshold size aneurysm, who perhaps have other comorbidities or perhaps have a cancer that we think, which do we treat first? This is quite a big aneurysm, but they've got a cancer. The majority of us would go ahead and treat the cancer. But, we might be able to identify patients who they've got a cold aneurysm rather than a hot aneurysm that we can leave for a bit longer, or conversely, a large aneurysm that needs treated soon because it's hot and we worry it's going to rupture or grow quickly. What I think is very exciting about the application of these imaging biomarker techniques is the potential for them to be used as surrogate trial endpoints. Now, there was a group who used USPIO MRI in the carotid arteries to evaluate statin therapy. And actually what they found was the use of high-intensity statin therapy was able to be evaluated using USPIO MRI in order to determine, and it was able to show that, in fact, inflammation in the carotid artery reduced quite quickly following the introduction of statin therapy. So in theory, we could potentially use these imaging techniques as surrogate trial endpoints, allowing us to perhaps evaluate new drug therapies or other techniques and use these imaging endpoints rather than clinical endpoints, allowing us to recruit perhaps smaller populations and follow them up for less time than we need to if we're waiting for a lot of clinical events. It might also help us with cost effectiveness. Now, here in the UK, we struggle. The NHS is a little bit broke, and we have to decide. And there's almost a sense of rationalising healthcare. And perhaps if we were able to do a test that said, "Hey, this guy's or this man or woman has a big aneurysm, but it looks cold. We don't think it's going to trouble them for the next couple of years," then maybe we will hold off on one of these expensive interventions. And also these techniques can allow us to give a global assessment of patients. And I'm about to tell you a little bit more about that shortly. So what's next? Well, I'm very excited. In Edinburgh, we've just installed one of the UK's only total body multiple tracer PET-CT. So in the short period of time, we're going to be able to scan a whole patient at once, whereas our PET-CT imaging studies to date have had to be different scans on different beds, so sort of 3 beds of the body in order to produce our aortic imaging analysis. We are going to reach pivot, and we're going to investigate peripheral artery disease. And I hope this can lead again to this idea of personalized therapy. So just quickly, we have a great unmet need in peripheral artery disease. Over 200 million people in the world have PAD. And of these, in the end stages, people need to have leg amputations. And, we know that there are high rates of concurrent coronary and carotid artery disease, very high rates, even if they're asymptomatic. Many of our patients will have concurrent coronary or carotid artery disease. And ultimately, what kills them in the end isn't their leg per se, but it's their heart attack or it's their stroke. And we've got a stubbornly high risk for major adverse cardiovascular events. If we take Basel trial and Basel 2 and Best CLI, so studies that are almost 20 years apart, despite the fact that we've got incredibly sophisticated advances in endovascular technology, if we look at the outcomes, they're not greatly different. So roughly the same number of our patients, despite the modern trials having less invasive techniques and very sophisticated techniques, broadly similar amounts of patients are still dying or needing a major amputation. So I think there's a real unmet need here. There's something we're not quite getting right. And I personally believe it's personalizing our therapy to an individual patient, including an individual patient's plaque biology. I don't think this one-fits-all approach is adequate. We just throw antiplatelets at people. We give them clopidogrel or aspirin or whatever our local and national guidance says, but we don't test for clopidogrel resistance as routine. We give them a statin. We just, we give these patients whatever brand of drug, whatever drug we feel they should have, but we don't make sure it's the right one for them. And we really should be doing that. Analogous to patients with cancer, for example, they're treated according to their molecular biology. And now our patients with PAD and chronic limb-threatening ischemia have a worse prognosis than many common cancers, and yet we're just generically treating them with one-fits-all approach. And so in cardiovascular disease, in peripheral artery disease, I'm going to briefly tell you about the use of dotatate PET-CT to evaluate inflammation, the use of 18F-GP1 PET-CT to evaluate thrombus, and again, our wonderful sodium fluoride PET-CT looking at microcalcification. And this is a study that I'm very excited about and I hope is going to be funded very soon. We're going to look at total body multi-tracer PET-CT in peripheral artery disease. We're going to assess 3 of the key processes that we all know are involved in peripheral artery disease, really to look at the plaque biology phenotype. We're going to look at all arterial beds. We've talked about the fact that many of our patients with PAD have concurrent coronary and carotid artery disease, and using our new total body PET scanner, we can look at all of these beds at once. So we're going to evaluate this idea of systemic plaque activity and remote plaque activation. So we know that patients who have an MI or an increase of another MI within the next couple of years, even if they've had their index lesion treated. And there's a theory that in fact you have plaque activation in remote arterial beds. So maybe one of your coronary arteries has had a plaque rupture, which is successfully treated, but in fact there's a plaque somewhere else that was hitherto quiescent, but because of your acute plaque event, this other plaque becomes activated and causes sort of clinical sequelae. And we're going to look into that as well. In a patient with CLTI who has end-stage disease and very high disease activity in their lower limbs, what's happening in their heart? What's happening in their carotid artery? If we treat that patient with PAD with a therapy, what happens then in the other parts of their body? And we're also going to evaluate a drug therapy. There's an upcoming study called the LEADER PAD study, looking at the use of colchicine in patients with PAD. It's already started internationally and is soon to open in the UK. And we hope through our multi-tracer PET-CT study to be able to evaluate the mechanism of action of colchicine in the lower limb arteries as well as the coronary arteries and elsewhere, and also to identify and sort of objectively evaluate these 3 disease processes: thrombus, inflammation, and microcalcification, and see what colchicine does to each of those. And all leading towards the idea of targeted therapy to the patient, but also to their plaque characteristics. So just to summarize, imaging biomarkers, the Hubble Space Telescope of cardiovascular imaging, they are non-invasive ways to evaluate biological signatures and to identify biological signatures that represent the potential for significant clinical consequences. These biomarkers can be developed for many disease processes. They have clinical and translational uses, including, of course, decision-making, treatment evaluation, and personalized therapies. And yes, they can be expensive, they are highly specialized, and they're reasonably limited availability. But I would argue that it's very routine to use PET CT in the evaluation of cancer patients. And remember what we said about cancer and PAD and how patients with CLTI, with tissue loss, have a worse prognosis than many common cancers. So if we're using PET CT in our cancer population to try and improve survival, I would argue then there's an argument for using it in our population as well. So thanks very much for listening if you've got this far. And there are, of course, a number of people to thank. This is all, this research has been collaborative with a number of my colleagues, all based in Edinburgh. And I'm excited to take forward our PAD study. So watch this space.